right, welcome everyone to our program today as part of our CLL 360 series. Today's is titled, It's Time for Treatment, Making the Right Decision for Me. So the goal is that you will walk away as patients and care partners with better understanding of how to approach decision-making with your medical team, and specifically how to understand how to approach decision-making with all these options that are balancing how effective treatment is with quality of life. And there's so much rapid change happening with some continuous therapy, some time limited. The ultimate question here is, what is the best for you and or your loved one? So a great conversation ahead. My name is Stephanie Trong. I am also a blood cancer patient advocate. I was diagnosed with non-Hodgkin lymphoma. And in that experience is how I decided to start the Patient Story, which is a platform that really aims to help people navigate life before, at, and after diagnosis in human terms. And we do this through in-depth patient stories, as well as educational discussions like this one, which, as we all know, is especially important for a community like those of you who are dealing with CLL, SLL. So engaged, knowing that you want to empower yourselves continuously throughout treatment, throughout all these decisions. We also want to thank the Leukemia and Lymphoma Society for its partnership in this program. The LLS offers incredible free resources, including but not limited to their information resource specialists, as well as their clinical trial support center, both of which are staffed to provide one-on-one support in different areas for the blood cancer community. We also want to give a shout out to our friends over at the CLL support group on Facebook, led by our friends, including today's moderator, Michelle Nadine Baker. And that really does offer this ongoing virtual support for folks dealing with a CLL, SLL diagnosis. All right, a little bit more housekeeping, and then we'll be off to the races, I promise. Before our speakers, we want to thank our sponsor, AbbVie, for its support, which helps us to host more of these programs and for free to our audience. The Patient Story retains full editorial control over all content, as always. And while we hope that this is incredibly helpful, this is not meant to be a substitute for medical advice. And the last piece of this, we really do care about what you think and what you think we could do better, what you want more of. We know there's lots to discuss, so please let us know all those things on the survey that will pop up after this program ends, and it should just take a couple to a few minutes. All right, with that, again, lots of great conversation ahead. I'm going to send it over to Michelle.
Thank you, Stephanie, and thanks to all of you for joining us tonight. I am so excited about our program, both as a health journalist and as a CLL patient, because shared treatment decision-making is so crucial for us. So I would love to introduce our guest tonight, Dr. Nicole Lamanna. She's the Director of Chronic Lymphocytic Leukemia and Professor of Medicine at Columbia University Medical Center. Thank you for joining us, Doctor.
Thank you for being a part of this.
So could you summarize, and I know this will be tough, but if you could summarize something I've always wanted to ask you, what drew you to specializing in CLL?
I'm surprised, actually, we haven't covered this topic, you and I before.
Exactly.
Mine's a simple, sweet story. Chuck, you might know this story. I don't remember, but I was a resident and I went to residency at NYU at Bellevue, and we used to rotate up at Memorial Sloan Kettering for cancer, for our oncology experience as residents, as interns and residents. And they always used to put me on the leukemia service. And so, for every year when I was an intern and then I was a resident, they put me on the leukemia service. And when I went back to my program after those rotations, when I became a third year, actually, one of the leukemia docs, kind of kept in touch with me, and he said, Nicole, what are you thinking about doing for your life? And I was like, I really want to be I was really into taking care of the whole patient. And so I said, I'm going to be an internist or a primary care physician. I love taking care of every part of the patient. And he's like, didn't we do that on leukemia when you were on the inpatient unit? Don't you remember we took care of infection and kidney failure and heart attacks? I'm like, yeah, you're right. We kind of did. And so, the more I thought about it, he's like, I think you really should think about oncology and applying to oncology fellowship. And sure enough, that little push, see, having good mentors did that little push for me. And so I decided to apply for fellowship, and then, went to Sloan Kettering and, stayed while I did my fellowship, of course, did my research with one of the leukemia guys, and sort of was taken under their wings and started working with a mentor in CLL, and hence there you have it. So
Wow, so mentoring is so important to
It
others then.
definitely
Look what it did for you.
absolutely correct. I would not be doing this if it wasn't for those guys. So I give them lots of credit.
Well, I'm so glad that you are in CLL. Oh, and also with us today is Dr. Charles Farber. He's a board-certified oncologist and medical director of oncology research network development for Atlantic Health System. He also serves as a clinical assistant professor at Rutgers and the Cancer Institute of New Jersey. Welcome, Dr. Farber. Now I'm going to ask you the same question. What drew you to specializing in CLL?
Sure, it's a little more happenstance. I was a college student and I was working in a laboratory, and we were, believe it or not, synthesizing morphine professionally, not for recreation. And I was doing structure activity relationships, and I got into an MD PhD program at NYU. And I was slated to go there and start research with a pretty well-known guy named Eric Simon. He coined the term endorphin, which we've heard of. But right before I got there, he moved up to Columbia. And there I was left with having to find someone with a research interest that would overlap with mine. And I thought, well, neurosciences, what's another great frontier in medicine, for which research is sort of an open field. And I came up with oncology and hematology and leukemia. And I looked at the faculty at NYU, and Robert Silber was doing cutting edge work in CLL. And I ended up joining his laboratory, ultimately getting my PhD there as well as my MD. So there you have it. So I was at NYU as well as a medical student and graduate student. And the mentor that I was originally going to work with went to Columbia. So you have sort of, closed loop here to some degree. And I've kept up my interest in CLL right through my career.
I'm very happy to hear that as well, because the more of you that know the ins and outs of CLL, the better for all of us who are patients. So I want to also thank our audience for being here, to be here for our program with shared treatment decision-making and how to be an empowered patient. For my frontline treatment, there was a simple choice back then, because I was diagnosed in 2012. And when it was time for treatment for me, and this was the end of 2015, it was a simple choice, just the standard of care or go on a clinical trial. So I chose a clinical trial, and luckily it gave me part of the standard of care and also in combination, the future of treatment. So I discussed all of this though with my CLL specialist, and we came to a shared decision for my treatment. Then when I relapsed again a few years ago, once again, I had to make a decision, but there were so many choices at this point, so many to be made, which is fantastic for patients, but it makes it a little more difficult for us to make the decision, but it's fantastic that we do have all this. So, doctors, the world of CLL has changed tremendously, with so many more treatment options for all of us, for clinicians, researchers, and patients. First, Dr. Lamanna, keeping in mind that we're limited in time, can you give us a summarized update on the current CLL treatment landscape? I know this is a big ask, right? And how it's changed, especially in just the last couple of years.
Okay, very briefly.
I know it's going to be hard.
I mean, I guess to allude to what Michelle was saying, really back in the day, we really just had chemo immunotherapy. And so regimens like fludarabine, cyclophosphamide, rituximab, or FCR, or maybe many of you have received, or bendamustine rituximab, or sort of chemo intravenous therapies were standard of care. So like Michelle said, we didn't have as many choices going 10 years or so back. Now we have these targeted small molecule inhibitors. So there are a lot of oral agents. The two big classes we have are what they call BTK, or Bruton tyrosine kinase inhibitors, or BCL2 inhibitors. And so these are oral therapies, and they'd sort of, have now the standard of care. And so patients can right now currently either take a chronic therapy with one of these oral BTK inhibitors, or you can get a time-limited approach with a BCL2 inhibitor. The only one we have currently approved is venetoclax, in combination with either a CD20 monoclonal antibody, either rituximab or obinutuzumab. There's lots more going on, which I know we're going to touch upon probably soon, but I just wanted to say, so those are sort of more of the standard care approaches now. We've moved away from chemotherapy, and now either people are on either BTK inhibitors or some sort of venetoclax-based therapy. So that's just to sum it up in a nutshell, but lots of stuff going on.
I'm extremely thankful for all of these new treatments. But this means, as I was saying, choices, and choices mean decisions need to be made. And this leads me to a fundamental question that many patients are hearing this term, shared decision-making. And my question is, just what does that mean? We're not entirely sure what shared decision-making means. And it's understood that doctors are the experts from a medical and clinical standpoint, and patients are the experts on themselves and what matters most. Dr. Farber, I need your help here to help explain in simple terms just what shared decision-making means when it comes to treatment and what the process typically involves.
Sure. So shared decision-making is a collaborative process where patients, often their family members, and the doctors sit down, communicate, and come up with a plan. And it's not just limited to a choice of treatment or duration of treatment. It's also in CLL in particular, because most patients, when they're diagnosed, don't need treatment. We observe them. We do watchful waiting, or as my patients refer to it, watchful worrying. So that's typically the first decision is what criteria needs to be met before treatment is offered, and if so, what the treatment options available to the patients, what are they, and what's best for the particular patient. And it's really individualized. So I think it relies on two-way communication, where the doctor may have in his mind what is best for the patient, but this isn't, Dr. Kildare, where they make the decisions for you. That's no longer in effect. We do shared decision making where that's appropriate. So I think it boils down to trying to communicate and impart the important information to our patients and their family and loved ones, what is best. And it's really interactive. It's not. It's really a dialogue, and the doctor with the experience and the knowledge has to work with the patient with their wants, exactly what they desire.
Well, you just dated yourself with Dr. Kildare, and I'm dating myself and even knowing who that is. I think I heard my grandparents talking about him. But, you're right. It is different now. And it's wonderful that doctors and patients have these lines of open communications. So Dr. Lamanna, what factors guide you in making treatment decisions, including, starting time for treatment and which treatment is optimal for each patient, or which treatments if a decision has to be made?
Yeah, I mean, this has become more complicated in both, Michelle, and as you guys alluded to, I think part of this, the shared decision-making has become more present only because I think, to be fair, we have more options. I think back in the day when we didn't, the options were, do you want therapy? Do you not want therapy? If we only had one option. And so it was a very different conversation. And now with all these options, it becomes a conversation of thinking about, not only, so first we always think about the genetics and the disease itself. So what is going on with the patient? Is it that their blood counts are bad? Do they have big, bulky lymph nodes? Do they have genetic features? What are the features of their disease? So we take into characteristics those chromosomal abnormalities. Do they have high-risk disease? These are things that you all might hear about, the deletion 17p or a TP53 mutation, or maybe multiple chromosomal abnormalities. So you have a complex karyotype. So we think about the disease, But then the other flip side is then we think about the patient and say, okay, what other medical problems does that patient have? What other comorbidities? Do they have heart disease? How are their kidney function? What are their social circumstances? Is this somebody who can get back and forth to the clinic or to the hospital frequently or not? Is it somebody who needs a lot of extra support? Are we choosing then, are we looking at therapies that might be easier for that patient too? So we do take those considerations, and that's where that discussion of that shared decision-making now comes into play when we talk about either BTK inhibitors or venetoclax-based therapy. What are the choices in that person's life at the particular time? There are some people who might have little kids and are busy and active and say, I need something sort of simple and not going to be too labor intensive for me, versus other people who may choose something different. They'll go for more intensive therapy because they can put in the time. So we do that shared decision making. So not just disease characteristic and comorbidities, but then the discussion, because of these major treatment options that are slightly different. They're both great treatment options. And albeit I'm going to argue that even though we talk about this when somebody's first going on therapy, and I know, Michelle, you did this because we talked about this a lot. The other option, of course, is that many people will wind up seeing potentially both of these options during their lifetime. And so, what may be relevant for them at this particular moment in their life may be different later on down the road. And so that'll come up again later when you talk about relapse or needing more therapy. So I think we take all of this into consideration when we're talking about the time when somebody needs treatment, into consideration when we discuss these different paradigms or these different treatment options that are currently available.
Given all this, Dr. Farber, this leads me to a really important topic, and that's quality of life. And, this last ASH is the first time I heard it discussed so openly and so frequently. It's an important factor for all patients when we're considering treatment options. So how do you balance the potential benefits of a treatment? And Dr. Lamanna just spoke a bit about this, but how do you balance the potential benefits of treatment with this impact on a patient's, their daily life, including time on and off therapy, or like Dr. Lamanna was saying, with they have young children, or if they have other responsibilities, or they're working and they travel a lot for work, which are wonderful questions to be able to think about, right, with treatment these days.
It's really a very complex equation. Within the last couple hours, just saw a physician newly diagnosed with a low-grade lymphoma, not CLL. And I was asking him, he's a retired physician, internist, and I was asking him about his personal life, what he enjoys doing. He was there with his wife, his family, and the wife interrupted and said, well, why are you asking these questions? I said, well, it's very relevant in terms of the big picture, what the goals of treatment are, what the lifestyle of the patient is, what they like to do, what they're willing to tolerate, how temporary is the initial treatment. Is it just a phase initially? Some of the medicines require more intensive monitoring initially before things get better. So it's really very, very important. Quality of life is life. And, whether someone's willing to sacrifice, people want to live longer, they want to live better. And what they're willing to tolerate, what they're able to tolerate, has to be assessed, and for how long they're willing to tolerate it. So it's really a very complex equation. And I think with these many variables, it really needs to be explored, starting with the patient, the host, the treatment options, what sort of side effects, what are the goals of therapy? Is it to make you live longer? Is it to make you live better? What are we trying to achieve? So I think, quality of life is a very important issue, and it's one of the more important variables in that equation. And I think you really, again, shared decision making is absolutely critical, where you can't do for the patient what you think is important. It really has to be a dialogue.
All this is music to my ears because, when I was on frontline treatment, it's not like there was something that could be a better quality of life. And I'll be honest, my quality of life was not so great on frontline treatment, but there was no, at that point, there were no choices. And I just want to share with other patients that, you know, we are so fortunate that we do have these choices now and that we can have better quality of life as CLL patients. So, you know, this is a great time to talk about learning about each of your approaches to treatment and learning about them. So, Dr. Lamanna, and then I'll come back to you, Dr. Farber. Dr. Lamanna, what are the potential advantages and disadvantages of a fixed duration treatment? In other words, you know the end date, it's not like it's going to go on forever. And, you know, talking about, you know, like a venetoclax plus, as you had mentioned before, in combination with either an obinutuzumab or Rituxan, or maybe just venetoclax versus continuous treatment, like a BTK inhibitor. So what's your approach on that? And should that be should these types of things be factored in when you're speaking with a patient and the approach you'll take?
Sure, absolutely. I mean, they are, because we usually, you know, to be fair, both of these treatment options are great. And so, you know, so then because now that we have both of these excellent options, I do take into consideration then we talk about both of these options and the logistics of both of these options and the pros and, you know, the advantages and disadvantages of going for either approach. And then we kind of align that with what, you know, what's going on with the patient at the time in their life. Unless there's something glaring where, as I mentioned before, unless there's something glaring, like they have a comorbidity or a medical problem where I really think that one drug might be better than another, then I will absolutely say that. I'll still discuss both of the agents, but I'll still bring that up and say, you know, I'm really concerned about this. And so I think you really should do this. So the point is you have these discussions, but now you're really actually, you know, you're talking to the patient and factoring in what their wishes are. So the advantages of being on a chronic, for example, just to get back to what you asked me, Michelle, sorry, I digressed. The advantage to getting a chronic BTK inhibitor is it's easy. It was the perfect thing, like during COVID, you don't have to really worry about tumor lysis, which is that breaking down of leukemia cells that can play havoc with your electrolytes and your kidney function. You didn't have to monitor for that. So it's an easy drug to start for people who are busy, you know, have an active lifestyle and don't want to, you know, make the time commitment of the being monitored very closely with a venetoclax-based regimen. It's easy to do a BTK. The downside is that it's chronic and continuous. And so some of the nagging side effects that we teach everybody about the BTK inhibitors that can, if you're taking it chronically, you know, some of these nagging side effects obviously can occur later because you're taking this as indefinite therapy unless you have a side effect. Or you progress. So that's the downside, is you're on a chronic medicine, right? That could have, you know, some uncomfortable side effects, diarrhea, GI issues, you know, cardiac issues, bleeding, bruising, things like that. The venetoclax-based combinations, the benefit is it's time limited. So it's very similar to what we used to do with chemo immunotherapy. So you're getting a short duration of therapy, you'll get off and hopefully you won't need to be on treatment for many years down the road. And so you get a break from therapy. The downside is that it's more labor intensive in the beginning, the first couple of months. There's a lot of monitoring of blood work. Your blood counts can fluctuate a little bit more commonly with the combination. And so sometimes you need extra help, some growth factor support, or your blood counts can decrease. They might have dose modifications. So there are some different logistics with a time limited approach that people have to be willing to commit to. But the advantage is you get a break off of therapy. So those are the I have both of these conversations with all the patients, because it is rare to say that somebody is precluded from one regimen versus another. And so that's why most patients have the option. As I said, there might be some circumstances either based on a comorbidity or based on cytogenetics or other issues that I'm concerned about with the patient, where I might recommend one approach versus another. And so that does happen, but we have that dialogue.
Dr. Farber, is your approach a bit different? And if so, how?
No, it's actually very much in line with Dr. Lamanna's.
Okay. Yes, thank you.
I really would echo what she said largely. I sort of summarize it, for the trainees, that the BTK inhibitors are very easy to start and hard to continue, whereas the BCL2 inhibitor, venetoclax, is very cumbersome to start, requires a lot of initial monitoring. The patient has to come in very frequently. lab work, a lot of sticks, a lot of hydration. Got a guy here pretty much all day as we're ramping up, but it's easy to continue. And then, of course, the issue about ongoing treatment versus finite treatment. Majority of people obviously would like to be treated with a finite therapy for 1 or 2 years. But that's not for everyone even. I mean, it's a little counterintuitive, but some people feel very comfortable being treated with ongoing therapy, where they feel like they're proactively being monitored and treated. A lot of people panic when it comes to the end of a year or 2 years on the venetoclax, and they are concerned. They offer anxiety about, well, what are we going to do now? I mean, it's not broke. Why do we want to fix this? I mean, what's wrong with continuing on with the venetoclax? So I think, again, shared decision making, it's individualized. So comorbidities, the age, the ability of the patient to come in frequently those first few weeks may dampen my enthusiasm for the venetoclax in certain individuals. If they're on a blood thinner, anticoagulant, I worry about that. With the BTK inhibitors. So I think it's truly a situation where the treatment has to be individualized, and there may not be a perfect treatment, but one clearly may be better than another. And I think discussing that, it's difficult when you get to that point. There's a lot of information there, and patients with CLL, you're an exception, Michelle. They tend to be older and have comorbidities, so you are quite the exception. But you do the best you can, and it requires a lot of patience, and but it's very gratifying. Historically, we have amazing treatment now. If you look back even 10 or 15 years ago, it was like prehistoric, particularly for patients at higher risk with unmutated immunoglobulin heavy chain or P53. We really didn't have very good treatment. We really had no treatment until, probably early 20 teens, with the advent of ibrutinib. So, it's a very gratifying time to be in practice where we have options and we can talk to patients about, what may be better for them.
So that leads me to the next question. And I'm sorry, I just have to ask this. What happens when a patient and their doctor have differing views on a treatment plan's next steps? And we've talked about when everyone's all happy, they all agree together. But what happens when you two don't decide? What do you do about this? While you're here, Dr. Farber, what do you do about that sort of thing?
I send them to Dr. Lamanna.
That's an excellent answer.
To some degree, the patient's always right. And, if you feel they're taking a misstep, if it's not a horrible misstep, you voice your reluctance, you voice your concern. If it's really, something terrible, you tell them you're not willing to do it, or, perhaps they should seek an additional opinion. But you try to resolve it. CLL, the C in CLL is chronic. So, if they want to take ivermectin or something that really is unproven, you try to educate them. You try to, intellectualize what's going on. But it could be difficult because, some patients just get an idea and it may not be a good idea, and they really feel very strongly about it. So if it's something you're really uncomfortable doing, you can just try to excuse yourself and offer a second opinion. It could be challenging, and some patients get offended when you don't do exactly what they'd like you to do. They could come at you with something from Dr. Google that isn't necessarily appropriate. I think, again, you just have to be calm and try to explain the rationale for why you think it may not be a great idea.
Okay, so I just want to clarify for everyone about ivermectin. So, Dr. Farber, could you explain what you would say to someone exactly if they brought that up, maybe in a few words?
Sure, I might tell them that there have been reports, anecdotal reports of patients doing well with a variety of diseases, but that's not really scientific. That doesn't prove that ivermectin is effective in a given setting. And I explain about randomized prospective trials, how the true way that this is done, the best way scientifically, is to take a group of patients, divide them in two or more groups. One group is treated with the test agent, the other is treated with standard therapy or observation or placebo. And the true scientific way is if the group that gets ivermectin actually does better. They live longer, have better quality of life, have objective improvements in their labs or radiographs. That is scientific, because sometimes in CLL and other diseases, there are spontaneous remissions, improvements, and single cases of patients getting better is really akin to snake oil, where someone comes up and endorses a treatment. So that's what I would try to explain. I try to explain that individuals getting better. I have a cousin who has a friend who got better on ivermectin is not akin to a randomized prospective trial showing clinical benefit.
You're very polite with your explanation and what you would say to someone about ivermectin. I appreciate that. Dr. Lamanna, so what factors what would you do if you and a patient disagree about what their treatment plan will be, their next steps?
I send him back to Dr. Farber. No. No, yeah, I mean, to be fair, it is a dialogue. I've been lucky, maybe I've just been fortunate. There aren't many patients that I've had real troubles with. I mean, I think the bigger issues has to be more of the discussion of patients who, because many of the patients, thankfully, are either wanting to hear the whole discussion, or have also read and then bring up all their questions with me. And so that really helps a dialogue, because you hear where they're coming from. What Dr. Farber is mentioning is if there's, sometimes if people bring up things that are completely not standard of care, or where then I'm having a conversation of, okay, this is the approaches that are standard of care, and then having a discussion about supplements, alternative medicines, and how to integrate those into current practices or therapies that might be needed for their leukemia. And whether or not, I mean, if somebody really doesn't want to take any sort of standard of care type medicines, then the discussion is, I'm probably the wrong person for them, right? So, and I have that discussion, and most of that really isn't so difficult, frankly. So that's really not difficult to have that conversation, or difficult, because either the patient has a right fit and doesn't want to have anything, is afraid to take any kind of standard of care therapy for CLL. And that's very easy to sort of to have the discussion with them and then see where they want to take that. The other really conversations when you think about second opinions are really when people are getting multiple opinions from lots of different doctors, and that happens, right? So many of us, I'm sure Chuck does too, we see lots of folks who have seen lots of people, and they talk about which therapies, and honestly, they're usually just talking about all the standard of care therapies, just in which sequence, and should they do that one first or that one first, and that kind of thing, or clinical trials, and let's talk about the different clinical trials. And that's great, because that's an open dialogue and right up my alley. So I'm happy to talk about any of that, and sharing my knowledge and expertise about those issues, and then coming to a mutual agreement, and if they want to do one or another, and whether that's with me or someone else. And so there isn't really, I've never, I guess, really had too many difficult, where we've disagreed, where it's been not approachable. Either, it's something that we have a conversation about. And I always say to patients that, because CLL is a journey, you need to find somebody that you feel comfortable with partnering with. And that may not be me, that may be someone else. And that's okay. I mean, because it's a long journey and they're with you for a lifetime. That's what you hope, is my lifetime and their lifetime, that they're with you for 20 plus years or more. Hopefully this will be a normal lifespan type thing. That's what we're shooting for with all our research. But you do want to partner with a doc and a team that fits you too. And that doesn't always have to be, I may not be the right person for that person all the time. And that's okay. And so, I respect that, and that's all right. So it's really I've never had too much difficulty.
It is, I mean, we have to admit, it's a long-term relationship. And it is important that you and your doctor gel. It's almost, I always say, it's almost like dating in the beginning, right? It's like trying to figure out who's right. But yes, I have to say my relationship with my CLL specialist is probably one of the longest, not quite as long as with my husband, almost. So, but so then let's move forward to second line therapy and third line. Dr. Mana, what factors do you consider, and are they different when selecting a second line therapy and also planning for future treatment options?
Yeah, as I said, this is really a journey. And so when I'm thinking, although most patients are really focused on their first treatment and what they're getting at that moment, I'm always thinking about their next line and their next line and their next line. So the goal is to try to think ahead with folks. And so in second or third line, you really take into a number of considerations. One is, what did they get in front line? Have the genetics of their disease, have they changed? Is it, that they once were a favorable risk and now they've, changed to having they've acquired now a 17p or a p53 abnormality? How did they tolerate their first regimen? Do they have new comorbidities that are different now, or on new medications that we have to be concerned about, anticoagulation or antiplatelet agents or other things? And so how then, depending upon what they got in front line, that will definitely play a role into what they're going to be recommended in second or third line, what their response duration was to that therapy in front line. So if they got a time limited approach with some ven-based regimen like ven obinutuzumab, how long did that last for? Was it short? Was it long? Did they tolerate that regimen? Is that something we can reconsider? If they were on a chronic BTK in front line, then we're not going to do, they're not likely we're not going to offer them another covalent, because most people at this point have gotten covalent BTK inhibitors in front line. We could talk about that later, I guess, or not, but we have time. So then the question is, then are they going to, if they're chronically taking a medicine, you're not going to switch them to the same class of a covalent BTK inhibitor. Then you'll likely go to a ven-based regimen. Then of course we have non-covalent BTK inhibitor, the pirtobrutinib just got approved. So how to sequence these drugs is still being evaluated, but the point is, we're still considering, it's important to know what they got in front line, have their genetics change, any new comorbidities, what their response was, any major side effects, and that all plays a role in second and third line.
So you just said something I'm going to ask Dr. Farber about, if their genetics change. Dr. Farber, as CLL patients, this is something that patients are always asking, did they change? Can they change? I had my test when I was first diagnosed. This is what it showed. Now that's showing something else. So what happens to our genetics? Is it from treatment? Is it what?
Sure. Yes, the genetics can change. If you look at newly diagnosed patients who've never been treated, perhaps 5-7% will have a p53 or 17p deletion. Whereas if you look at patients who are populations of patients who are very heavily treated, particularly with chemotherapy drugs, it could be up to 50% of those patients will have the dreaded p53 mutation or 17p deletion. So yes, by treating, you do one of several things. You can introduce new mutations, or at least select out for a population of cells that have that mutation. So what is very important is a patient who needs a new line of treatment or is having progressive disease, if they haven't had genetic testing, and there are a variety of different assays that are used, FISH and next generation sequencing and so on, they really should be checked again because there may be something emerging that was not there or not recognized earlier. So I think that's very important. So yes, it's not the same biology through the course of the disease in a given patient. It can sincerely change in part through the treatment. And that's one of the reasons in general we tend to try not to treat patients until they really need treatment. There's the IWCLL criteria for who needs treatment. So not everyone needs treatment. We try to avoid it. They say there's no benefit to treating early. I would take it a step further. There may be detriment to treating a patient before they need treatment. It's like shooting off your ammunition before the war begins. Yes, I'm seldom accused of starting treatment before an individual really needs treatment. So a patient really needs to be, if they haven't had a genetic profile of their disease in recent times and they progress, you really should, be checked out again.
Dr. Farber, we only have really 2 questions left here, and one of them is for patients. What is your advice to them how they can most effectively advocate for themselves and share decision-making conversations with their doctors? Especially when they're just so overwhelmed. Like, I know that some of what we covered today may be overwhelming for patients, and I just suggest that maybe if you feel that way, you watch that part of our program again, and we'll try to explain it more. But it's a lot of information when you're not a doctor. So what do you suggest in how they can more effectively advocate for themselves, especially when, well, and also when their hem-onc is not looking at the newer therapies. Maybe, they're in a rural community and they don't have that advantage.
Sure. So, I think it's imperative that perhaps the patient, again, this is a disease of older people. They may not hear as well. They may not, pick up on the nuances of the visit. I think it'd be important for them to bring in a relative, a spouse, a loved one, a child, to review what the doctor is saying at one of these critical junctures. I think that would be important. I think it's important to write things down. I think that when all said and done, the patient can actually come up with like a little chart that's effectively like a profit and loss sheet where you see the pros to a treatment, the detriments, the cons to a treatment, and you might have one for each of the different treatments that are being offered to you. Listen carefully to the doctor. You can ask their opinion. If you feel that they're not really being committal, well, what do you think? Do you think one is better than the other? Do you think they're equivalent? What aspects of one treatment would be better than another treatment? What aspects would be inferior? Are there any nuances to my current medical state that might make one treatment better than another? So I think, coming up with, very focused questions. I think writing things down before you go in, rather than it be sort of a free-for-all, something that's fairly organized. So I think it's, back in the day, we really didn't have options. There was, one best treatment, and we could, change the doses. We can change the schedule a bit and try to finesse it. But now we have real different options. We have different agents within a given class. And, I think it's important that the doctor and the patient come up with a good plan for the individual.
Dr. Lamanna, do you have anything to add to that?
No, I mean, I agree. I think that patients, it's often good to bring somebody to their appointments because it's hard to hear everything with one set of ears. And what sometimes what for the patient might be focusing on, their loved one or friend or significant other might hear other aspects of the conversation. The one beauty I think about, if there is anything to say in terms of the difference about CLL compared to other cancers is, usually, we can have multiple conversations when we're sort of gearing somebody up for treatment. And so I often encourage, them to write down questions and bring them for their next visit, or to message us. And we actually spend a lot of time going through this. Thankfully we have that leeway and that little bit of flexibility of doing this at multiple sessions to try to get people, answer their questions, but to go over the treatments and discussion more commonly and more thoroughly, I think, than sometimes for some other cancers where you have to make immediate decisions. That's very rare. Not to say it never happens in CLL, it sometimes does happen, but you have the luxury of doing that. We also try to set up educational visits where it might be just telemed to go over the drugs and the side effects. We do that as well. Oftentimes support groups are, the one thing in CLL is there's lots of good support groups, and this is one of them, where they really can go over questions. I hook patients up early. When I first meet them, I actually give them a book. I give them a whole thing. I do. And then I write down, so they get a little book from LLS talking about CLL. And then, I give them websites. I say, if you really want to, I don't think I say to patients, not everybody's ready to get online and look at their disease, and Dr. Google can be a problem. But for those who want to, I say, if you're going to do this, I want you to go to reputable sites that talk about the disease. And here are some good support groups. And I list out a few and give them paperwork that has all this information so that they can go online if they're ready for it. There are many patients who shouldn't and aren't ready for doing that, and that's overwhelming, and they shouldn't. We talk about that. But again, it's sort of these types of things. We have very good support groups for CLL patients, and these sort of multiple conversations and bringing advocates is very helpful. And that's what I tell people to do.
This has been wonderful, doctors. I've learned so much from you, and thank you for your devotion and dedication to helping CLL and SLL patients. And now we all better understand this shared treatment decision-making, how important it is in our journeys. And to all of you watching, I want to thank you as well for welcoming us into your homes with our program. So we just presented so much information to you. It's a lot. You can always catch a replay of this on our Facebook group, a support group like Dr. Lamanna was speaking of. In this one, I'm one of the co-administrators, and it is called, quite simply, CLL Support Group on Facebook. So you can catch it there if you want to go back and review some things, or if you maybe you had to step away at any times. So I'll be sharing a link for that as well. And just thank you for being here. Back to you, Stephanie.
All right. Wow. Thank you so much, Michelle. And thank you to Dr. Lamanna and Dr. Farber for all the work that you all are doing. Again, not just with the patients you are seeing yourselves, but all the work that you're doing to help patients everywhere. In CLL and SLL. It is so important to be empowered, again, especially in the space of this disease, which requires a lot of engagement and understanding because there's so much rapid development happening with different therapies. So again, thank you so much. We really want to, again, ask for your voice because we are reading your feedback. So please take the time to fill out the survey that will pop up after this program wraps. We also want to thank again our sponsor, AbbVie, for its support of this independent patient education program. And also to our partners, the LLS. You'll check out the links on the side for the LLS websites. Again, Information Resource Center, as well as their Clinical Trial Support Center that provide free one-to-one support. And also the CLL support group on Facebook that offers an active community of patients and care partners with so many different backgrounds. I hope that you were able to learn something from the program, enjoy it, that it spurred some thoughts, and that you can walk away from this with some actionable items on your list of things to do. For now, we are done with this program. We hope to see you at a future one. I'm Stephanie Trong for The Patient Story. Take good care.